Hello and welcome to the Completed Life Initiative's latest symposium, Last Hellos, New Models in Global End-of-Life Care. This symposium asks the question, how do we navigate one of life's most transformative experiences, our dying?
Drawing inspiration from Australian poet Les Murray's observation that these kind of questions summon last hellos. Today's Global Symposium welcomes speakers from Australia to Belgium, the United States to Rwanda, as we explore new models in end-of-life and palliative care.
From the origin of what it means to be palliative in the context of Aboriginal communities, to the scientific inquiry into the effect of placebos, from research into personal narratives of end-of-life visions, to expanding eligibility considerations for medical aid in dying. This two-day symposium invites you to contemplate one of life's most powerful transformative experiences.
Your presence in this virtual space means a lot to us, and we are grateful for you tuning in today. Be sure to stay till the end of this presentation, as there will be an opportunity for you to join a Completed Life Initiative team member and your fellow symposium attendees at our virtual event cafe. Thanks for joining.
Hello and welcome. In this session, our topic is, can artificial intelligence help us make better end-of-life predictions? It is my pleasure and honor to introduce my guest, Dr. Charles Binkley. Dr. Binkley is a hepatobiliary surgeon and bioethicist. He is director of bioethics at Hackensack Meridian Health and associate professor of surgery at Hackensack Meridian School of Medicine. He is also a bioethics fellow at the Markula Center for Applied Ethics at Santa Clara University in Silicon Valley. His academic research is focused on artificial intelligence systems which support clinical decisions, particularly the need to inform patients, shared machine-physician agency, and assigning moral responsibility for AI-guided clinical decisions. Dr. Binkley's work has appeared in Cancer Research, Annals of Surgery, the Journal of the American College of Surgeons, JAMA Surgery, AMA Journal of Ethics, the American Journal of Bioethics, the New England Journal of Medicine, and Verdict. His book, Encoding Bioethics, AI and Clinical Decision-Making, will be published in June 2024 by the University of California Press. Welcome, Charles. We are so glad that you are joining our symposium.
Sarah, thank you so much for the opportunity to talk with you today and to engage with the larger community of completed life.
In this global conversation, we are exploring new ways to approach end-of-life care, from the benefit of art in palliative care to indigenous practices. And I wanted to explore with you something that the concept of which is the focus of your forthcoming book on AI and clinical decision-making, as it applies to improving end-of-life care. So to begin, I'm wondering if you might share how you came to be interested in and work with artificial intelligence as a form of assessment in your clinical work.
Well, absolutely. As you mentioned, I'm a hepatobiliary surgeon by training. And so I practiced liver and pancreas cancer surgery, mostly for cancer, in San Francisco, California for about 15 years. And I went to San Francisco right out of my training at the University of Michigan. And when I arrived as a young, very gung-ho surgeon, I was doing a lot of surgery for pancreatic cancer in particular. And after 2 or 3 years, I noticed that a lot of those patients that I had operated on, I would follow up on them, I would review their chart, that they had died. And they had died of recurrent cancer within those first 2 years. And I was really very troubled by, did I do something wrong? Did I not predict well enough? Did I not inform them well enough? I knew the data, and the data were and still are that about 80% of patients, even who are treated with optimal surgery, radiation, chemotherapy, will have recurrent disease within the first 2 years. And I found myself thinking, can we make better predictions? Can we better determine who will and who won't benefit from surgery, or what benefit they'll derive? Not so that we can say to people, we're not going to operate on you, but so that we can better enter into informed consent with them, and have patients better understand the limitations of surgery. Right now, I would say to patients, there's an 80% chance you'll have a recurrence. I don't know if you're going to be in the 80 or the 20. The only way that we can find that out is for you to undergo surgery. And surgery involves a lot of suffering, a lot of pain. Even if it's controlled, you're still going to have pain and suffering, potential complications. And so that's the background. I left clinical practice in 2019 to really focus on ethics. Found myself in Silicon Valley at the Markkula Center, which was probably one of the best things that have happened for my career. And they're really engaged in AI scholarship with some of the leading AI technology ethicists, business ethicists, internet ethicists, to really think about, what is this tool? What is AI? And each of my colleagues was thinking about deploying AI models in their own area of expertise, and I was thinking about it in healthcare and biotechnology. And they were each asking, so what's the ethics framework? And I found myself saying, well, fortunately, we have an ethics framework. The doctor-patient relationship into which an AI model is going to be deployed has normative expectations already, and we don't need to revise, we don't need to revisit, we don't need to come up with a new set of ethics. We have a rich tradition of ethics in that relationship. We just have to figure out how that applies. And so that's what I found myself doing, is really trying to apply bioethics to AI, thinking about it in terms of relationship, and thinking about the collaboration is primarily between the clinician and the AI model. And then that collaboration then results in shared decision-making with the patient. So that's a bit about my journey and how I see AI as being having great promise for the future, and helping us make better decisions, helping us manage clinical uncertainty, which every healthcare decision is met with clinical uncertainty. And the way that we typically resolve that is time. We intervene and we wait and we see. And hopefully we do less of that. Hopefully our predictions are better. But I do think there's some concerns that we have to address in the interim.
Well, thank you for that. And what a wonderful journey it sounds like it's been. So I'm grateful that you're in this space now to share with us your experiences. So I've learned that Hackensack Meridian Health now has the Serious Illness Care Connect program, which is I believe, a pilot program. And I'm wondering, how has this Care Connect program, how does it work? And what has your team and your colleagues, what have you discovered so far during the time that it's been operational?
So there's a great question. I'm going to answer it a little more broadly, and think about how these models are being deployed in healthcare systems really across the country, across the world. I have a colleague that I collaborate with in Canada, and mortality predictor models are being deployed in the hospital systems there. So I think that they have great promise, like all the AI models do. And so what is the benefit? What's the intended use of these models? The intended use would be able to more accurately predict a patient's risk of dying within a certain period of time, oftentimes 6 months to a year, so that patient has that information, and the clinician has that information, and they can better enter into informed shared decision-making. The other advantages are that information can be used to have the patient see palliative care, have the patient potentially see hospice services. And the idea is that clinicians are very bad at making that prediction. We're very bad, and we know that empirically, we're very bad at predicting someone's mortality. And so by giving this information that's validated, that seems to be very accurate to patients and to clinicians, we would be able better to align goals of care, particularly at the end of life. So that's the intended use. That's the purpose behind it. But as we unpack it, there are lots of potential unintended uses that are concerning. There are potential conflicts of interest that may also be concerning. There's lots of questions about whether patients should be informed and consent to having the prediction made. We're not always very good at discerning what patients' informational preferences are. Do you want to know this information, right? We presume, oh, this is beneficial, so we're going to tell you. Some patients may not want to know, and I feel that we would be infringing on their autonomy if we force them to know something they don't want to know. Conversely, they may not want that to be known, period, right? And so do we allow patients to exercise autonomy over their data? So a patient can decide, I don't want my data used for this purpose, right? So, I think data ownership, I've been told by my legal colleagues, is rife with difficulties, but I think about it as data sovereignty. I think about the physician, the clinician's commitment to confidentiality and privacy. We profess that to patients, and in the age of Hippocrates, it was that we won't tell anything that we heard. In the auricular age, in the written age, it was we'll make sure your medical records are locked up and that nobody can see them. And now it's the digital age, and where health information it's much harder to control. And we may not tell your neighbor that you have a serious illness. So I don't think that's the risk right now, is that, that somebody will be told, but rather that information could be used to profile you across platforms. It could be used to limit your access to healthcare, could be used to limit your access to social services, and potentially also employment. So there are myriad concerns about these models that I think many of us share. There's the intended use, and then there's the unintended uses. Another potential unintended use is that clinicians could see this as a surrogate marker for futility. So that even if a patient says, I would like to have, this series of treatments, despite the fact that my mortality is predicted to be low, what if the clinician says, well, you're going to die anyhow. I'm not going to do that. That's an inappropriate use of healthcare. And so that's concerning. I think another adjacent concern is these mortality predictions are being made at a discrete point in time. And we're relying on the clinician to know whether or not that mortality prediction is fixed. So if somebody has terminal cancer and they're predicted to have a 6-month mortality of 85%, that's made in a certain point of time. But what if what if the patient, a similar patient with cancer, comes in and that cancer is very treatable, but the clinician doesn't understand that prediction is made based on how the patient appears at that given point, and that with surgery and chemotherapy, that patient's 6-month mortality may go from 85% to 10%. Now, I think about this in the context of metastatic colorectal cancer to the liver. A patient who presents with metastatic colorectal cancer to the liver without treatment, and that's how the mortality predictor would make the prediction, patient has about a 20% 5-year survival. But with optimal treatment, the patient could have an 80% 5-year survival. And so you can see how the ability to mitigate, the mortality predictors are predictors based on a period in time, and they don't necessarily factor in can the prognosis be mitigated. And so my concern is also that people simply take this as the truth, and they won't think about mitigation strategies, because there may be. I also think about, and I know I'm giving you lots citing lots of instances for concern. But another concern with how these models can be used, or other unintended uses, is is how do we disclose this to the patient? How do we tell the patient about this? Again, getting back to the informational preferences, how we disclose it to the patient. But I think we also have to think about what it means to the patient. Does it take away their hope? Does it cause them to identify themselves differently? And what if the clinician disagrees with it? We talk about the importance of having the human in the loop. But what if the human in the loop actually could prove to be less beneficial than the AI model? What if the human in the loop holds the AI model back? And I think about, a mortality predictor that may predict a certain mortality for a patient. And the clinician looks at the patient and looks at the mortality predictor and dismisses it and says, "Oh, this is wrong. This is wrong." Well, what if it's right? What if it's right? And what if that patient dies in the next 6 months and would have benefited from knowing that information for all the reasons that we've talked about? So those are sort of at a high level some of the things that concern me about these AI mortality predictors. There's something different about predicting that someone's going to die in a period of time than predicting that somebody can develop chronic kidney disease, or predicting that somebody's can develop some other disease process. This seems different from a value sensitive perspective.
Well, thank you for that overarching summary of your concerns and really charting a path forward for some things that we might look at in our discussion today. And you alluded to the idea of prognosis, and you mentioned Hippocrates, and I want to zone in on that for a moment. And the idea of prognosis, or the prediction about the likely course of treatment in one's disease, is a notion that you and I know have been around for millennia and debated for millennia. The Greek physician Hippocrates and his Hippocratic oath recited in medical schools, specifically indicating how physicians should do no harm. And I think what you're zoning in on in your list of concerns about AI predictive models of mortality is really how to ensure that harm is not incurred in the patient. And so in your article entitled "From the Eyeball Test to the Algorithm," which was published 2 years ago in the New England Journal of Medicine, you quote the adage, "Good surgeons know how to operate. Better surgeons know when to operate, but only the wisest surgeons know when not to operate." And I was curious about why you included this statement in your research, but particularly in the context of AI. How do you assign moral responsibility to AI as it helps guide clinical decision-making?
Yeah, it's a great question. I'm going to start kind of with that last piece. How do you assign moral responsibility to an AI model? Well, right now we're not. We're kind of sidestepping the debate by saying, well, we're going to keep a human in the loop, and so ultimate moral responsibility is going to be assigned to the human. And I think that that's probably a temporizing measure. I think we've got to think very robustly. So when I went to medical school, and I tell the medical students this all the time, I run an AI ethics lab with about 10 medical students, and we talk about, we're teaching them how to interpret a blood test. We teach them how to interpret a CAT scan. If they go on to a specialty, they may learn how to interpret an EKG or an echocardiogram, but we're not teaching them how to interpret an AI predictor. And as long as these models remain in the laboratory and we have them in a controlled setting and they're being validated, I think that the risk of harm is much less. But it's once they're deployed, it's once they fall into human hands that we have the greatest risk of harm. Currently, and again, this is uncharted territory, there hasn't been an attempt to assign moral responsibility to the model or to the clinician, but at a certain point, harm is going to occur. An important question that I think we have to ask is, are we going to accept less harm from an AI model collaborating with a clinician than we do from the clinician? Although Hippocrates says, first do no harm, we think about it slightly more as don't unintentionally harm, or make sure that if you're going to harm, that the balance of harm to benefit is skewed toward benefit. Because as a surgeon, I there was, you operate on people and you take out organs and people, bleed and they have complications. And so there's lots of harm, but the idea is that the harm should be geared, it's a necessary in order to achieve some benefit. And so, what level of harm are we going to accept from the models? And then, to what extent are clinicians going to be expected to follow the model's prediction, regardless of their own assessment? Right now, the emphasis very much is on, you can reject this if you want to, which has the potential to be a little bit intellectually dishonest. Can you really? If everybody's expecting you, if everybody's touting the power of AI, is that going to bias you in favor of it? And are we all as clinicians going to abdicate a bit of our responsibility? Because what if the model has discerned a pattern that we haven't? That's the whole idea. I may know the risk factors for lung cancer, but I'm going to miss a certain number of patients who are going to develop lung cancer. I'm not going to screen them. Because I don't know all the factors. I potentially can't recognize the patterns that an AI model can. And so the moral responsibility question is one that weighs on me. And right now we're saying where there's a human in the loop, the human has the ethical obligation, and so the individual can simply reject it. But what if that rejection leads to harm? What if that's the irony? What if rejecting the model actually results in harm? Is the clinician also accountable for that? Is that how we assign moral responsibility? If we think about our epistemic authority based on our training, our education, our experience. So what if we say my epistemic authority is greater than the model's epistemic authority? So I will reject what the model says. And what if harm results from that? Right now, I think we would say, well, the clinician exercised their moral responsibility. They made the best clinical decision that they could, and they were wrong, like we sometimes are. But what if that happens over and over again? What if the model actually is found to be superior to the human? Then I think at that point we have to think about what is the moral authority of the model. There are some legal scholars who argue in favor of an AI insurance policy. So models would be underwritten, and if harm occurred, there would be some sort of compensation for that. And it may look like the vaccine fund, where all vaccine manufacturers contribute, and if harm arises from a vaccine, then it's compensated through this fund. Others feel like it should be private insurance, that these models should be privately insured. And this is not really moral responsibility, but medical legal responsibility. And so there are those who believe that the underwriters will help to ensure high quality AI models if they're on the hook for harm. I think about it as, are we assuring that our clinicians really have the tools to evaluate the model's prediction and to incorporate it into their clinical decision making in a robust way, holistically assessing it, understanding the pluses and the minuses. I think a potential conflict of interest that has the potential to cause some moral distress is that some of these models, and even the mortality predictor model, has not just clinical benefit, but operational benefit. And I'll give you an example. So healthcare leaders are very interested in reducing in-hospital mortality. Payers are very interested in reducing costs at the end of life. And one of the concerns is that, are these models ultimately operational, or are they ultimately clinical? And they can certainly be both. But if you're gonna err on one side or the other, you would want to increase the clinical benefit and decrease the operational benefit, rather than vice versa. And so to use these models as a way of, sort of coercing patients into signing up for hospice so they don't die in the hospital, and the hospital doesn't have increased inpatient mortality rates, or coercing patients to change their goals of care so that they're not spending a lot of money at the end of life. Those conflicts of interest concern me. And I think, who's going to bear the moral responsibility for that? Is it going to be the clinician? Is it going to fall on the clinician to know whether these models are being used primarily clinically or operationally? And it's not going to necessarily be transparent. This is part of the opacity of the system and the trade-offs that the system has been programmed to make. So I think about that in this context, about moral responsibility. And so at what point does the health system, at what point does the AI programmer also bear moral responsibility?
Well, thank you for that. And I hear your many concerns, and I agree wholeheartedly that there are many ethical landmines waiting in this pioneering, brave new world. And so I champion the work that you're doing and being brave enough to step forth and figure these problems out, because they are the problems of the next many generations. And so thank you for the work that you're doing. And I want to take a step back and help our audience think through first the benefit of these AI mortality predictor models. It seems as though AI can be used to appropriately give clarity of medical prognosis so that the patient and their physician might have better clarity around decision making. The problems with that potential clarity or better enhanced clarity aside, how does the innovation of AI as a helper in improving these end-of-life assessments gauge or perhaps account for potential room for error? Is there a process of checks and balances, if you will, within the algorithm? Or if not there currently, are there attempts or plans to implement those potential checks and balances?
Yeah, so I can speak to that from a couple of different perspectives. One is that the current system of checks and balances is very much the clinician. And you can see that difficulty if we already say that clinicians are not very good at prognosis, right? And so we're giving them a prognosis, and if they disagree, we're telling them to reject it. So it seems a little bit of it seems to be a bit of a conflict there. So if we know the model is going to be better than the clinician, then should the clinician simply accept the model? But right now, the clinician is the check on the model on the model doing harm. So I think about it from that perspective. I also think about it from the perspective of a learning model. So these models have been validated sometimes on 750,000 a million unique patients with sometimes 10,000, 20,000 unique data points for each, and we basically in an unsupervised way say make the associations and the predictions. And we don't know how those predictions are being made. We don't know what information is given the greatest importance in making the prediction by the model. The model simply says, here's the desired outcome that we want you to predict, or in the case of death, the undesired outcome, and use these data to make that prediction, and it makes the prediction. And then the idea is that as the model makes the prediction, we will follow those patients out, and we'll see how well the model did. And we will use the current patients that are contributing their data. They will then be, that will become learning data so that the model can continue to learn, continue to improve its predictions, continue to weight various pieces of data so as to improve the accuracy of its prediction. So those are kind of the ways in which the model will have some system of checks and balances. There'll also be other checks and balances in terms of issues like equity and making sure that the models aren't biased. There are going to be equity audits that will be done that will make sure that there aren't groups of patients who benefit more than others or who are more burdened than others by the predictions. And so I think when I look at equity, I think about the equitable distribution of benefits and burdens to make sure that one group doesn't benefit more or one group isn't burdened more by the prediction. So that's the system of checks right now. Ultimately, will it be a legislative system of checks and balances? Generally, clinicians have self-regulated. Whether there'll be superimposed regulations. One of the things about regulations around AI is that you either are going to create a regulation that's so broad that it's not really going to apply to all the different implementations, all the ways in which AI can be implemented, or it's going to be so narrow as to really restrict the use of AI. To say I'm not going to use AI in healthcare is simply not going to be feasible. AI models are going to be used to run the centrifuge, the CT scanner, the staffing ratios, every aspect, I think.
Triage ratios, I'm sure, as well.
Triage ratios, clinical decision making. So I think to say, we're not going to use AI is just not going to be practical. In the same way that teachers are grappling with, what is the appropriate use of AI? My husband is a law professor and very much is grappling and helping his colleagues grapple as a leader in the generative AI and legal education arena, is helping his colleagues grapple with, how do we let students use these models? And to just say, I'm not going to let them, and if they do, I'm going to give them an F, is not a reasonable approach, really, because not only is it not feasible, it also doesn't prepare them for their careers.
Well, thank you for that, and it's such an important point to help us learn how to adapt to these emerging technologies. And this new model of mortality prediction is incredible on the one hand, but also a little bit daunting on the other. And so you mentioned health equity, and I wanted to go back to that for a moment. I'm curious about, in the context of different healthcare communities, from extremely rural to suburban and urban, how might this new and emerging model of end-of-life prediction, whether or not in the palliative care context, using artificial intelligence benefit diverse populations?
Yeah, it's a great question again, and I'm going to think about it from a couple of different perspectives. I'm just going to make a couple of notes so that I don't forget. So let's think about how these models are going to be validated in their local ecosystem. And so what if, as you mentioned, there may be areas in which palliative care is not available. Patients don't have access to palliative care. So a prediction is going to be made, but they're not able to really access the thing that prediction is meant to be tied to, and that's, palliative care services or potentially hospice services. These models may not all be as accurate in certain ecosystems as others, and so they have to be validated in the local ecosystem. Although a model may be trained, it may have been validated in an inner city, that may not work for a different population. And so it's really important that when these models are adopted, is that they're validated and they're proved beneficial, that they're clinically piloted in their local ecosystems, because we know that they're not generalizable. They have to relearn, they have to adjust to the population for whom they're making the prediction. The other concern that I have about equity, and that is the diverse populations of people, particularly patients living with disability. We can do equity audits for race, gender, age, because those are oftentimes very transparent markers. They're oftentimes self-reported, but disability status can be slightly more opaque. And mortality predictors are probably not going to have been trained on as robust a data set from patients living with disability. And so the model may well overpredict or potentially underpredict someone living with disabilities mortality risk, which is deeply troubling, particularly for a vulnerable group of patients who've oftentimes been discriminated against based on their disability status and not offered interventions that were presumed to be futile because of their disability, or not being offered interventions because the idea was that it was a limited resource and someone else would benefit from it more because of that patient's disability status. So I worry a lot about how the model would fail with certain groups, even though it may work. So for instance, we know some models work really well on some groups and less well on other groups. There's a left ventricular assist device model that was reported that works really well on older white men, because that was largely the data set on which LVADs, it was older white men who had been selected previously to get LVAD. So all of the information that we had, or most of the information, was from older white men. But so it didn't work very well for women, for instance, or for people of color. And so we can assess for those things and either train the model more broadly or put a warning label on it saying it doesn't, the model's not accurate for these groups. But when it comes to patients living with disability, for instance, or patients living with chronic disease, it may work less well and in ways that we can't necessarily either predict or easily audit for. And it may well be that what I would like to do is raise the attention in this area first, and not have it be, oh gosh, we've made some mistakes that we now have to go back and correct. Part of my my role as an ethicist is to think about unintended harms, and then also to think about unintended harms and how do we assess for them. How do we audit for them, so that if we get a safety signal, we can respond to it by looking at it more closely.
So many important and fascinating facets to think about and to ponder as we move into what I like to call the AI generation coming forward. I'm curious, about this idea of how do we ensure cultural safety for diverse communities, including patients with disabilities?
Yeah, again, it's a great question, particularly when somebody has dual diagnoses. And it'll just be very difficult to know how the model is making the prediction. And is the fact that somebody's living with cerebral palsy or someone's living with trisomy 21, would that affect their cancer diagnosis? And how would the model, so the model may be trained on data from patients living with disabilities that had not received optimal care. And we certainly see that with our lower socioeconomic status patients who may not have received optimal, and I think about it from a cancer perspective because those are the data that I know best. So patients may not have received optimal cancer care because they were lower income, and those patients are disproportionately Black and brown, and so it looks like Black and brown patients die from cancer at higher rates than white people do, which is true, but it's not because of anything intrinsic to them. It's rather the result of many times the care that they received, the treatments that they received. I think about the sort of foundational paper from Obermeyer and colleagues at the University of California in Berkeley that highlighted some of the bias concerns and really raised them and illustrated them very eloquently in their article. And so in this particular model that they looked at, patients' past healthcare expenses were used as a proxy marker for how sick the patients were. And the idea is that the sickest patients would be given lots of resources at discharge in order to prevent them from being readmitted, because hospitals, health systems want as low a readmission rate as possible. And so you can see where the error was, the algorithmic assumption was wrong, was that healthcare expenditures do not predict the level of illness. It's actually inversely proportionate. People who are the sickest actually don't have access to healthcare. They don't have access to preventative care. They don't always have access to acute care. So instead of healthcare expenses being a marker for how sick you are, they were actually a marker for how wealthy you are. So the wealthiest patients in this model, the wealthiest patients spent the most on healthcare and were given the most benefits at discharge. And then the patients who were actually the sickest had spent the least on healthcare. They were the poorest patients, again, disproportionately Black and brown, and they got the fewest resources at discharged. And so I think about that perspective and the data that we're using. Sharon Valor, who's a technology ethicist in Scotland, just wrote a book called The AI Mirror, and I'm making my way through it, but part of her premise is that if we're going to use data from the past to make predictions about the future, are we basically going to be stuck, right? Are we ever going to make progress? We're going to be repeating the cycle over and over again, and we're basically going to be just staring at ourselves into the future.
Wow. And I'm curious, relying on mortality being predicted and kind of the Wild West that presents in an ethical, medical, and legal perspective. Earlier, you mentioned that in these AI predictive models, you're relying on that fixed point of prediction for their prognosis. And I'm wondering how might you guide or alleviate patients' fears about their end of life in the context of AI potentially helping that end of life experience?
Again, it's something that I think about a lot. And I've largely focused on helping the clinician understand the limits because, I think about it as two decision points. First, the clinician will collaborate either because they request or because a prediction is pushed out to them. So the primary collaboration is actually between the clinician and the AI model. And then the clinician will then take that information from the AI model and think about how to assimilate it into their recommendations to the patient. The patient may not actually be informed that part of the information that the clinician uses from an AI model. And then the patient will be expected to enter into shared decision making. But you can see how expecting the patient to actually be part of that is going to be extraordinarily difficult because the patient may not even know that their data has been used. And so I was actually there's a paper coming out in the American Journal of Bioethics, and I'm collaborating with some colleagues to write a response to it, in which they're basically saying that making sure that the patient is in the loop will be a bit of a safeguard, a system of checks and balances. And I think that's putting an undue onus on the patient. I think absolutely patients should participate in model development. They should help us identify what problems they want the solutions to. They should help us with developing these models, with thinking about optimal user interface, how they would want them used and not used. But I think expecting patients to play a role in accepting or rejecting, again, particularly even when the models may be opaque, I think that that's placing an undue onus on patients. I think part of our professional responsibility, and I see my clinician colleagues do this on a regular basis, where they say, okay, we can do X, Y, and Z. What would you like? And I think about this, from the perspective of, And then the patient says, I want X, and then it doesn't go well, and the clinician says, well, they wanted X, so I gave them X. And I think that's a bit of an abdication of our responsibility, and I also think it's a misperception of what autonomy is. Our role is to give the patient to help the patient decide what their goals are, and then our role is to decide if those goals are obtainable or not, and what we can do to help the patient obtain those goals. And the goals can be extended survival, they can be increased function, decreased suffering. But I think if we start from goals and then back into interventions, we're on much firmer ground in terms of how the patient participates in the process. One of the issues with AI models is they're going to be encoded, they're going to be programmed to predict a specific outcome. And if that's not the outcome that the patient desires, then the model is probably not going to work very well for them. We may actually come at some point, and I think this is an interesting thought experiment, particularly at the end of life. What if, as a clinical ethicist, I see all the time where families interpret a patient's advance directive and say, well, they said this, but they really kind of meant this. And we have to rely on, I don't know the patient as well as their family member does. I've learned through a process of humility that to go in and tell a wife or a husband, a spouse of 50 years that a piece of paper knows their loved one better than they do is just complete arrogance. That doesn't mean that those pieces of paper are not important, but they have to be interpreted within the context of a life. These are check boxes sometimes. And as one spouse told me, she started off by saying, listen, honey, if you think that piece of paper knows more than 65 years of marriage, I have something to tell you. And it was a wonderful moment of humility for me. So will we develop a model where we each have our own personal AI that really knows us, like really knows us? And will that AI model be able to participate in end-of-life decisions with us? Would that be a more robust representation of the patient than their advance directive? Because I sat down with my father-in-law about 4 or 5 years ago. He wanted to complete his advance directives. He's a retired palliative care nurse. And he wanted to come up with every possible clinical scenario and how to address it. And I said, you're gonna box your son in. You're gonna force. You can't possibly come up with every scenario. What you want is someone who knows you well and who loves you a lot, because I think better decisions are made based on love than necessarily robust details.
Beautifully said. Thank you. Well, as we come to the conclusion of our time today, I want to thank you so much for sharing your expertise and insights today, Charles. And it's been wonderful to speak with you and learn from you. And as we conclude this symposium session, what key takeaways might you suggest for our audience when thinking about the complexities and wonders of AI and predictive models at the end of life?
Yeah, overall, I would say trust your clinician, trust the person taking care of you, and you can ask the difficult questions. I'm going back to this idea of what is the patient's role in all of this? What is the patient's role? And I think that just as we talk about automation bias affecting clinicians, where the clinician is going to say, oh, this model is so much better than I am, I think patients have to be concerned about automation bias affecting them, where they say, oh, these models are so much better than the clinician, right? I remember as a young attending, patients would come in and everybody wanted an MRI because an MRI was better than everything else. These models have their limitations. And so the idea, are we going to get to the point where patients come in and ask their clinician, did you collaborate with an AI model? I think about, I live right outside of New York City, and Weill Cornell Medical Center advertises on NPR very frequently about their touting their superior clinical analytical ability by using AI and machine learning. And are we incentivizing patients to want this based on our desire to create trust? And so I would say that for the time being, trust your clinician, and think carefully about the role that you want AI to play in your care. There are certainly some benefits, but there's some concerns.
Well, beautiful. Thank you so much. And thank you to our audience for listening in. It's been great to explore AI and predictive models at the end of life. Thank you, Charles.
Thank you, Sarah. I certainly appreciate it. And thanks to the Completed Life Initiative community.